I have no conflicts to declare. Thank you for the invitation to speak at this meeting. Today I will be discussing the ending the HIV epidemic pillar, Diagnose, which is the first pillar of EHE. The goal of this pillar is to diagnose all people with HIV as early as possible. Where we are today, despite the 2006 CDC recommendation that all persons between 13 and 64 years of age be tested at least once, population engagement has been suboptimal. Approximately 1.1 million people in the United States are living with HIV. 14% are unaware of their infection. In the current era of highly effective treatment and interventions, approximately 38,000 new infections are still occurring annually. However, it seems that the trend is tipping downward. We must address the shortfall in testing awareness and engagement with the right testing approaches that are supportive of individual needs. The aim of the 4 pillars of EHE is to drive HIV incidence to a low reproductive rate by the year 2030. Greater saturation of testing is essential to assessing this benchmark. CDC efforts for the Diagnose pillar are working in collaboration with communities and other agencies to increase local capacity to expand HIV testing according to CDC guidelines, so that all people with HIV in the high burden areas receive a diagnosis. CDC efforts involve some key approaches, using the latest systems and technologies to make HIV testing simple, accessible, and truly routine in healthcare and non-healthcare settings. The use or expansion of telemedicine and telehealth, an expansion of HIV self-tests or mail-in self-collected test kits. There are some challenges to testing. Some socioeconomic barriers include stigma. Stigma is a leading barrier to seeking testing. There are some financial considerations, such as being able to take time off from work, having appropriate transportation to get to the testing site, and the test costs themselves, as well as awareness of testing opportunities. Some challenges in the technical arena involve being able to identify suppressed infection events under PrEP and other biomedical interventions in the pipeline, which may drive down viral load or antibody detection. Likewise, this may be the case for rapid start of ART, which may lessen the analytes for diagnostic detection. There are some challenges in the availability of self-testing options that meet individual needs. And additionally, there are limited approved specimen types for testing to be able to meet diagnostic needs. And these tests require rigorous FDA review, which sometimes limit their ability to come to market. Factors affecting the use of HIV testing algorithms include local technical capacity, the costs of some testing platforms and whether laboratories are able to afford them, being able to adapt to ever-changing approved technologies, which may then drive updates to diagnostic algorithms. And all of these efforts would require an ability to link to care, which is vital for driving down the epidemic. The current recommended diagnostic algorithm for laboratories takes into account assay sensitivity, the ability to differentiate HIV-1 from HIV-2, and test costs. Currently, a sensitive antigen antibody immunoassay is the first step that, if positive, would be resolved as to HIV type in the secondary differentiation assay. If this test proves negative, then a third step, which is quite complicated and more expensive and not widely available, of the nucleic acid test would be necessary. However, there are new high throughput nucleic acid tests coming to the market for HIV-1 and or HIV-2. And these assays may be able to be used as the second or third step, depending on their intended use and availability in certain markets. There are diagnostic algorithms for non-clinical settings, which would begin with a rapid test at a testing site and may be confirmed by a second rapid orthogonal test, that is, a test of a different type, to confirm infection, or specimens may be sent to laboratories if available in the area for a complete algorithm or an abbreviated laboratory algorithm, each with different associated costs and ability to resolve diagnostics. New area of focus is HIV self-testing. HIV self-testing empowers people in providing greater control over individual testing needs. Self-testers, when provided with multiple tests, are known to distribute tests to their friends. Self-testers have demonstrated an overwhelming capability to perform the test. And a meta-analysis of clinical studies among MSM showed a 1.9 increased frequency of testing. This resulted in 2 more tests within a 12 to 15-month period and also doubled the likelihood of an HIV positive diagnosis. From this analysis, there was no indication of harm attributed to self-testing, and there was no significant increase in risk testing behavior. I'm going to go through some gaps in testing technologies, beginning with self-tests. Fingerstick blood rapid tests for point-of-care or self-testing are not currently approved in the United States. Fingerstick blood often improves sensitivity over fluid testing and would be a better option for people who need more frequent testing. Likewise, simplified point-of-care nucleic acid tests could benefit the needs of very frequent self-testers. Additionally, they could provide better screening sensitivity for initiating PrEP programs over that of serologic assays. All of these methods could be benefited by well-validated specimen types for self-collection. Various specimen types could provide multiple options for diagnoses, viral suppression detection, testing of antiretrovirals or other chemistries, and support telemedicine. There are gaps in laboratory-based testing. This includes total nucleic acid testing on whole blood. The combination of RNA and DNA increases the number of diagnostic targets available. Viral RNA can be associated with many blood cell components. As the image shown here on the right, HIV was associated with platelets, and that those targets would be missed with today's conventional plasma testing. Additionally, broader multi-analyte multiplex assays, if available, can be highly sensitive bead-based assays for the detection of HIV antibodies, antigen, and nucleic acids. Various combinations used in an algorithm could be an earlier indicator of PrEP breakthrough or identify occult infections. In conclusion, there's room to grow in testing, from the lab to the living room, to achieve EHE goals. The availability of new technologies can help overcome some of these recognized barriers. Self-testing through self-empowerment could increase the frequency of testing and help sustain engagement in care. Understanding and delivering the testing options desired by individuals, local organizations, and laboratories will be vital to the Diagnose pillar. Thank you for your time.